All right, so now I have to get you out of my way. I'm sorry. Here we are. Okay, so this is actually one of my favorite presentations because it talks more about what we do here at LunaSpad. Although at LunaSpad and DavisPad and Continuum of Care in general, especially the CRS programs, we do comprehensive holistic care. A great deal or a great part of the treatment that we provide in our residential level of care is therapeutic interventions in different modalities, individual therapy, group therapy, and like we've been talking about before, the bottom-up approaches, or the approaches that include some adjunctive therapeutic activities that use the different parts of your brain. So we're going to go over the different therapeutic modalities and what they help with. So hopefully, by the end of this presentation, you'll be able to learn about the different evidence-based approaches. That includes top-down approaches, which is like individual and group therapy, and also the different therapeutic modalities within the top-down approaches. So we're going to go over the cognitive behavioral approaches, and that those are all the sort of CBT and its descendants sort of therapies. And then the insight-oriented approaches, which are psychoanalysis and its descendants. And those are the main sort of like modalities of therapy that are used in general, both in individual and group therapy. Then we're going to go a little bit over what group therapy is. And within the group therapy, we'll touch on the bottom-up approaches. Okay. So CBT, or cognitive behavioral approaches. And when I refer in this case to cognitive behavioral approaches, I refer to, again, CBT and its descendants. The reason why I start with CBT is because CBT was the first cognitive therapy, the first top-down approach that was developed from the behavioral movement. And then after that, all the other modalities that you'll hear about, including REBT, DBT, and all the other motivational interviewing that I don't think we go over here, but all the things that you hear that are focused on the here and now and focus on behavioral change descend from CBT. So the principle of cognitive behavioral approaches is that the psychological problems are based on unhelpful way of thinking. And the psychological problems are based also on learned patterns of unhelpful behavior. And people can learn better ways of thinking and better ways of behaving. These therapies do not focus on history, do not focus on the past, do not focus on necessarily gaining a great deal of insight to start changing behavior. And one might think that it is important to be an insightful person, and it is important to know where things come from. Having said that, that can come as we change behavior. I think some of you have heard us when you've had your family meetings or in other occasions talk, for example, about behavioral activation. That is a CBT technique that basically addresses the behavior and helps clients change the behavior before they can go and do more in-depth work. Why? Because once you change the behavior and you get used to practice a new way of doing things, you might find that it makes you feel better and want to continue doing it. So these therapies focus on that. Anything that is unhelpful, your thoughts, your behaviors, your feelings, if you can change them, you can start the process of living a better life. The strategies that these cognitive behavioral approaches use are to learn to recognize the distortions of thinking. Basically, learn to recognize what's the fallacy or what's the lie of your thinking. For example, right? People do something wrong sometimes. And if you have a tendency to have negative thinking, you might be like, oh, I never do anything right. The fallacy with that is that you did something wrong this time, but the never ever do anything right might not be necessarily true. So learning to identify that pattern of thinking, that black and white thinking, that all or nothing thinking, which is a very common distortion of thinking, might be, if you get into that practice, might make a difference on how you feel about your everyday life. Or like if you have a bad interaction, a social interaction, and you conclude that no one likes me. Again, black and white thinking, all or nothing thinking. Maybe a better way to look at that would be to think, maybe I don't get along with these people, but I can probably figure out how to find new friends or something like that, which is more realistic and probably more in touch with reality than saying, no one will ever like me or no one likes me. So a lot of these kinds of thinking, this very binary thinking, if you want, or this very black and white thinking, is usually the one that causes problems and becomes very, very unhelpful for us. So of course it brings thoughts into reality, right? It's kind of impossible that no one ever will like me, or it's kind of impossible that I would do absolutely everything wrong. So a more realistic thought would be like, I made a mistake now, but I'll try something else, and that might work. And then again, say in the same line, using problem-solving skills to cope with difficult situations. In other words, this is difficult. What else can I do? It helps us face our fears, and in part it helps us face our fears because when we think black and white or very, very all or nothing, we're going to be more afraid that if we think that maybe things will work if we do something different. So it also decreases the threshold of our fear, and it utilizes some mindfulness techniques to calm ourselves down. It's important when you see this picture on the screen. It's important to know that cognitive behavioral therapy and all the cognitive behaviorally based techniques understand the human experience as a sort of puzzle that has pieces, and that includes your thoughts, your feelings, your behaviors, and actually some of the cognitive behaviorists now add the sensations in your body as a fourth element of this puzzle. And especially CBT therapies used to be very much into, there is a linear sort of relationship in between all these things. So you have to find the thought to change the feeling, to change the behavior. As things have evolved, CBT, but DBT and other CBT-based techniques understand that sometimes some clients are not able to find the thought, but they might be able to identify the feeling, or they might be able to identify the sensation in their body, or they might see a behavior that is unuseful, that needs to change. And again, as long as you find a way to put the first piece of the puzzle, you have a way to change your experience. So if you identify your behavior, again, just to go back to behavioral activation, if you identify a behavior that is not working, I'm not getting out of bed, and I get out of bed, even if I don't understand why, I might be able to then change my feeling. Oh, I got out of bed, I feel better. And then start identifying the unuseful thoughts that made me stay in bed. So as these therapeutic approaches have evolved, there's more, because of this added flexibility, more problems have been able to be addressed. So the founder and the creator of CBT is actually Dr. Aaron Beck. He recently passed away. He lived for years in Philadelphia, has a big it's the Institute of Cognitive Therapy that now it's run by his daughter. And a lot of therapists that want to train on CBT techniques will go to his institute to train. So originally CBT was developed for depression, and it's still very, very effective for depressive symptoms. But lately it's because, again, there's more elements of therapeutic techniques and more flexibility to the use of these therapeutic techniques. These days it works very well in anxiety disorders, substance use disorders, eating disorders. and even in there is now CBTP for psychosis, and it's actually pretty good. And a lot of the same techniques that are used for anxiety or depression work very, very well for severe mental illness, which is really, really nice, because before the development of CBTP, there were very little therapeutic techniques identified as effective for more of the psychotic illnesses. It leads to significant improvement in functioning and quality of life. And again, it's because it doesn't focus so much on where does this come from, but it's more how can we fix this. And it can be as or more effective than other forms of psychological therapy or psychiatric medications. And this is especially true for negative symptoms of psychotic illness. Currently, the treatment of preference for psychosis is actually medication, like medication management with antipsychotics. However, antipsychotics address primarily the positive symptoms of schizophrenia, meaning like delusions and auditory hallucinations and agitation. So antipsychotics do not address negative symptoms, which are more like the lack of motivation, the lack of engagement, the lack of the not getting out of bed, and all the sort of things that are more impairing. And CBTP has been found to be very, very effective for that. I'm looking at the questions. Does continuum of care offer CBTP? So what I would do is I would ask specifically if CIBH, our clinical component continuum of care, has someone that can do CBTP. I can tell you that at CRS, most of our clinicians know how to use CBTP, and it's no different than, it's very similar to using CBT. I believe that one of the main therapeutic modalities that CIBH uses is CBT, so I wouldn't be surprised if they're using CBTP. Techniques that CBTP uses, just because you hear about this, are, for example, like I said before, behavioral activation. There is also the disputing of irrational thoughts adapted to psychosis, and the main use of this kind of thought disputing for psychosis is teaching the client to address the value of the thought, even if it's a delusional thought. How valuable is this, right? Like how important is it in my life to believe this psychotic thought, and the power of this thought, or the power of this, like auditory hallucination, for example. How much do I have to hear this voice? Do I really have to hear what my brain is telling me, right? Because the assumption is with psychosis, you might have the symptoms anyway. You might not be able to completely be free of these very powerful thoughts. So it's teaching clients to accept that you're not going to be free of these powerful thoughts, but that you can question the value of it. Again, do I give value to this? And two, do I have to do what this thought is telling me? And the more that we can question this, the more free we can be, even if we still have the symptoms. And of course, the behavioral activation helps with the negative symptoms immensely, right? Which is basically do things to feel better instead of feel better to do things. All right, so let's keep going. So again, this is the CBT triangle, and they're all connected. Like I said, in the past, most of the models add these three components: thoughts, behaviors, and feelings. Lately, the models add also the physical sensations. So sometimes clients won't be able to tell you how they feel or what they're thinking, or even show you any behavior, but they can identify that their belly hurts or that they're feeling tense. And then that is the first piece of the puzzle. That first piece of the puzzle can help you identify what's going on behind that belly ache, or behind that feeling tense, or behind that urge to pace and not be able to be quiet. And again, because of this evolving of CBT, now other disorders are being treated with CBT very, very effectively. REBT is a spin-off of CBT, and actually it was founded by Dr. Albert Ellis. I am old, and I got to meet him. Actually, I got to go to a workshop with him in New York City. He has the REBT Institute is in Manhattan, and it's still operating, and they still provide training for a lot of aspiring therapists. He actually was originally a psychoanalyst, so he used insight-oriented therapies, but found out that for some clients, and it's the same kind of clients that we treat here on continuum of care, for some clients, psychoanalysis, insight-oriented therapy was just too long, and because it was too long, not helpful, right? People needed to start feeling better quicker. And so he modified his thinking to start practicing more in the way of the more behavioral approaches. So he focuses on the present. He helps people identify their currently held attitudes and beliefs, and the current maladaptive behaviors. He does actually use a lot of humor in his therapeutic approach. So he uses what therapists call Socratic conversations. So he helps people through their Socratic dialogue. And if you know what, like if you've studied logic in college or something, you might have heard of what Socrates did, right? He basically asked questions, and more questions to kind of make evidence what didn't make sense in the conversation. So that's sort of what he does. He uses a lot of questions to make evident that your thinking or the thinking of his client might not be logical, right? And because it's illogical, it sometimes ends up making the client, and it makes it very funny, right? And it's in a very, very gentle way. So if a therapist comes to you and tells you, well, it's impossible that no one will like you, you might feel offended, or you might be like, you don't know what you're talking about. No one really likes me, right? He will go in a much more gentle way and be like, for example, oh, so here your boyfriend, I guess, doesn't like you, right? And then obviously if the person is there with their significant other, they might be like, oh, well, he doesn't know what he's doing. He likes me, but he doesn't understand that I should not be liked or something like that. So the dialogue goes and goes and goes, and it sort of corners the client into this this doesn't make sense. I mean, this person obviously likes me, and that's my evidence against my thinking that no one likes me, or things like that. Oh, you do everything wrong, but can you hand me that piece of paper? And oh, good job, you hand me the piece of paper, something like that. And he will be like, I guess you don't do everything wrong. And then he goes through this dialogue of well, here is your evidence. You actually, your thought is actually unuseful. And then encourages the clients to find more evidence that what they're thinking, it's illogical ultimately, but very, in a very gentle way. So it's a very fun therapy, if you would. And then Marsha Linehan is the woman that developed DBT. For those of you that don't know, Marsha Linehan had her own, and she self-disclosed this. She had her own experience with borderline personality disorder of herself. And she was actually, where DBT was born, interestingly enough, was here in Connecticut. She was actually hospitalized at IOL, the Institute of Living, for self-harm behavior. And when she was there, she had quite a difficult experience there. And the part of why she had a difficult experience is because IOL was using very much CBT to address the problems of their clients. With it was it is evidence-based treatment. But Marsha found out that she couldn't get herself calm enough to practice CBT, because what happens with borderline personality disorder, it's that there is a lot of behavioral dysregulation or emotional dysregulation. And so she was always dysregulated, so she couldn't think about, what is the end useful thought, what is the end useful behavior. She was like just too activated to think those things, and she's like, I can't do CBT. So she figured out, well, what I find that this could be useful, but I can't do it. So she figured out that in order to do CBT, to actually utilize the same model, she needed to introduce a pre-step to do in CBT. And what she introduced was a mindfulness step before actually practicing CBT. And that's how actually the 4 pieces of the puzzle enter the sort of the CBT model, right? She figured, I am too dysregulated to figure out what I'm doing or what I'm thinking or why I'm doing it. I don't care. But if someone tells me how does my body feel, I might be able to say, why I want to punch something, or I want to hit myself, or I want to do this. And that's again the first piece of the puzzle, right? And sometimes DBT introduces these very, very basic techniques to manage body reactions, breathing exercises, mindfulness experiments, like using your senses. What are you hearing? Where are you? How is your body feeling in the chair? Things that can bring you to more regulation, so you can actually then think about the other pieces of the puzzle. So it teaches again how to change what is, meaning what's happening in the moment, and how to accept what is, which is important for people, especially with emotional dysregulation, because sometimes part of why we are so dysregulated is because we cannot, accept that we are having this thought. We cannot accept that we're feeling depressed. We cannot accept that we're feeling angry. We cannot accept that we're feeling anxious, and therefore everything is a mess, and I am just going to deal with it with this inappropriate, unhealthy behavior. So acceptance is part of the initial mindfulness step that is added to the CBT model to effectively address any disorder that might have emotional dysregulation, and that's how DBT kind of works. All right. And then there is a number of mindfulness-based other techniques, and these are used for a number of things. Mindfulness-based stress reduction and MBCT and ACT are other techniques. They are very good, for example, for substance use disorder, for dual disorders. And again, they introduce the mindfulness as the beginning of the therapeutic approach, and then the more CBT techniques. Some of the tools of CBT are adapted to the specific disorders, and they put a lot of less emphasis on changing the cognitions and more in accepting the cognitions, because that's another important thing an important difference when you're addressing disorders like DBT or even substance use, right? Think about someone that is addicted to a certain substance. Even if you want to change how you think, you really want the substance that you're addicted to. There's no changing of that thought. So if I'm going to try really hard to not like my drug of choice, I'm going to fail. It's a much better strategy to say, I'm going to accept that I am willing to die for this substance, and yet I have to practice, these techniques to not actually die for this substance. So I guess a lot of these techniques that introduce mindfulness are designed to address the symptoms that cannot be changed. These techniques are also used very successfully for example, OCD, right? Because part of the OCD symptomatology is that you have thoughts that you cannot get rid of. And if you try to get rid of, or you try to, use the Socratic technique to like combat them, or to try to like make them logic, it doesn't matter. Like OCD thoughts are not logic, and they're going to be there, and they're going to be torturing you, because that's what OCD does. So these sort of modified approaches help with accepting these thoughts instead of trying to change them, and are much more effective because then there's not this stress that I'm doing all these things and my thoughts are not changing. And it becomes, it's okay if your thoughts are not changing. You can still change your behavior, you can still change your feeling, you can still reduce your stress by using these techniques. All right, specific techniques that cognitive behavioral approaches use. EMDR is a cognitive behavioral approach, and that's used mostly for PTSD and to address traumatic experiences. ERP is exposure and response prevention therapy, and this is the par excellence technique used for the management of OCD. Behavioral activation, I've talked about this a lot. Par excellence behavior technique for depression and negative symptoms of psychotic illness. Trauma-focused cognitive behavioral therapy used for PTSD. And for the management of what is complex trauma. We use that, at least I do, with a lot of our young adult clients that have an extensive history of trauma. And the young adult services of the state of Connecticut actually does teach the clinicians that do work with their clients these techniques. So they're, again, par excellence, evidence-based treatment for complex trauma. And CBTP, we spoke about that too. They apply CBT therapy for psychosis, especially to manage clients that are stable but still have negative symptoms or residual, psychotic symptoms that are kind of annoying to them. Okay. Insight-oriented therapies. These are, again, the therapies based on psychoanalysis. And you've all probably heard about Sigmund Freud. He was wrong on many things, many things. But also, he was a man of his time. One of the things that he did right was to explain to most practitioners of his time that there was more to the eye, more that was seen. The next slide has actually I'll go there, and then this will be again on the next slide. This is the iceberg. This iceberg model was actually the way that Freud explained to people that there's more to the eye than just what you see, right? Before Freud, there was no psychiatry, there were no therapies. So if you had a psychiatric disorder, you will go to the doctor, and the doctor will be like, I don't understand why you're cutting, or I don't understand why you're not getting out of bed. And they were like, okay, well, I guess I'm going to give you, something to have more energy, or I'm going to give you something, a Band-Aid to put in your cuts. But they didn't understand, or they didn't have a model to explain that there were a lot of other things underneath the surface, that what you saw was not necessarily all that was. So Freud was right about this. He presented to the world the fact that the conscious, what you see, is only a very small part of what's going on with us, that there's a lot more inside that you, as a practitioner or as an spectator, as a family member, as a doctor seeing a patient, you will not see, right? The techniques that he developed to see the unconscious, to see what's behind, are still used by people that practice psychodynamic techniques. Free association, which is like, if you think about therapy, you think about, a therapist and then someone in a couch. The couch is used to do free association. When you're on the couch, you can speak about whatever you want and say whatever you want, which is free association. And pretty much the therapist will sit there, and as you've seen in movies, they'll just probably say and not interrupt, because you're free associating. But if you are free associating, you are able to access some of your unconscious. And then that same therapist that is just listening might be able to say, hey, every time you free associate, you always talk about this. Can you tell maybe more about that? And then that might help you get insight, which is the name of these therapies, right? Insight-oriented therapies, about what's behind, like underneath the iceberg. They use dream interpretation because insight-oriented therapists do believe that dreams are a way for the unconscious to show itself to people. Definitely you need to be trained on dream interpretation to do that. And there's still a lot of psychoanalytic schools, especially in New York City, that do teach this. But it's not just like sort of like, you know, it's not like witchcraft. It is actually when you do really go to the Psychoanalytic Institute and learn how to do dream interpretation, you do learn specific techniques and a specific meaning of certain things before you can just like, come out with like some weird explanation of what a dream is. It's that, it's the same training that you will get, for example, to interpret a Rorschach test, which is a personality test that most psychologists use. It's the similar techniques to interpret dreams or to interpret the responses to a Rorschach. And then exploration of the past. Again, as the person is sitting in that couch, and this is traditional psychoanalysis, we'll talk a little bit about spin-offs that are not that long and they don't let you just talk on a couch. Insurances usually don't pay for this because talking on a couch will take forever. Usually as you are in that couch doing free association, you will end up, telling stories about the past, and that therapist that is sitting next to the couch will encourage the person to talk about the past and to try to figure out how these things associate. It helps individuals understand why they feel the way they do. So this is what you expect from therapy. It identifies unhealthy patterns of behavior. It increases self-awareness. It identifies healthier ways to cope with difficult emotions, can lead to positive changes in relationships, and it's a powerful tool for self-discovery. It's really good for those that want to do self-exploration. It's really long, and some clients, especially some of our clients, don't have time to. I mean, it'll be nice to do once you're better, but at this point, you're sort of in crisis, and you wanna, be better before you engage in this. But it's a nice exercise, and again, I don't think it's covered by insurance because it takes a long time, which is the minus of this. There are, as I said, we're gonna go into in a little bit into the other types of psychoanalytic or base therapists, but there are shorter types of psychotherapy that is insight oriented. So this goes into the same thing. The behavior is influenced by unconscious thought. The therapeutic relationship is central to psychodynamic therapy, and that's important because psychodynamic therapy is the current practice of the old school psychoanalysis. Usually the duration of the therapeutic relationship is shorter. I mean, people will be, if you hear stories about people being in psychoanalysis for years and years, in the 60s and 70s. These days, psychoanalytic therapy is sort of the modern version of psychoanalysis, and it takes not that long, maybe a year or so. And they focus more on two things: the therapeutic relationship. So they explore transference and countertransference, and I'll go into that in a little bit. And they explore defense mechanisms. And by exploring this, they identify the way that people the things that people hide behind, and also the recurrent patterns for avoiding stress. So let's go into transference and countertransference. That's basically the feelings that anyone has on a relationship. When you have a relationship with anyone, you have transference, meaning what you think that people is thinking about you, what you think that person is feeling related to you, what you think that person might do because of you. In other words, you put your thoughts or your feelings on that person. Those are just based on what you think, not necessarily on what the other person thinks, but that happens to all of us, right? We meet anyone, we have or even people that we have a relationship with for a long time. We sometimes attribute things to that person that might or might not be true. And maybe we know them well and our transference will be more accurate, but in general, transference is that what we think and feel about the other, or what we think and feel the other person might be thinking about us. And the counter transferences are the feelings that that person causes on us. So, and that's very important, especially on the therapeutic relationship and for the therapist that practices this, because countertransference helps the clinician understand their client, right? So if for example, I enter a room and I'm having this conversation with this new client and I am scared of the client, right? I might be able to dig into my own experiences as to what makes me scared to understand my client better, right? And again, I'm going to be very psychoanalytic on you, even though I don't practice psychoanalysis, but I might be like, oh, well, my father used to yell at me, and this client yells a lot. That's why I am scared of this person. And that might be what this client causes on other people, because he is so irritable, he ends up making people scared, and then he thinks people don't like him. So, and then I can sort of return that to that client and say, well, let me tell you a story. You were just talking and I felt scared. And let me tell you why I think I feel scared. And that might help that client gain insight into how he relates to people. So those relationships are very, very important in the process of the psychodynamic treatment. And then the other very important part is identifying the defense mechanisms. There's a bunch of defense mechanisms. The ones in here are actually not all of them. But for example, repression, which is a very common defense mechanism, would be like, you look like you're upset. Oh, no, I'm not upset. That's repression, right? I'm not going to talk about it. I'm not going to be upset. I'm like, what do you mean I'm upset? I'm not upset. Meanwhile, you look like downcast and, have like the facial features of someone being upset. Or regression, right? And that means that you reverse to functioning at a younger stage of development. So I am a young adult and I'm in college, but I fail a test and I start crying and throwing temper tantrums, right? Regression. I'm functioning like a 10-year-old, but I'm an 18, 20-year-old. So, and sublimation is something that we use, all of us use. And Freud used to sort of explain this as, even the healthiest of people does have defense mechanisms. So, like you see on the drawing in the picture, right? There's this guy boxing into a punching bag, right? That's the perfect example of sublimation. I might be angry at my family member, but I'm gonna go to the gym and punch a bag instead, right? So I'm not gonna need to punch anyone else. I'm not gonna have to break anything. I'm not gonna do anything. I'm gonna just punch a bag and be like a boxer, and that would be the way that I deal with my anger. That's sublimation, and we might do that, right? Like we punch bags, we go to the gym and run, we like eat chocolate, we do these things. Those are all sublimation practices that we quite often use to deal with uncomfortable feelings. So anyway, as the therapist explains this and works through the relationship with the client, that's how the client does gain insight into him or herself. Then you have Gestalt therapy. Gestalt therapy uses similar techniques. The only difference is that Mr. Pearls and his Dr. Pearls and his wife Laura decide not to focus so much on the past, but to focus on the present. And they analyze the relationship and the defense mechanisms on the present, not so much in the past. They again recognize that no one can be fully objective because all of us have something under the iceberg that influences our thoughts and feelings, and that that sort of iceberg is influenced by our environment and our experiences. So that's how the past and our environment play a role. But whatever is happening right now, it's happening now. That's basically what he said. They don't use any technique. There's no techniques for Gestalt therapy. This is another therapist that simply holds space, right? So you go there and they sit very kindly with you and let you talk and see where we get. Again, probably not covered by insurance because it'll take a long time. But you also have to understand that a lot of these techniques or therapeutic modalities were developed before like managed care got into the world. So they will like hold space and let you explore, and then eventually you will get there and gain more insight about who you were. So obviously, also these techniques are not favored by insurance these days. More of the cognitive behavioral approaches are in general favored. The feminist approach is actually a favored by insurance, especially these days. And it says there specializes in female gender, but lately it's been very, very helpful for the LGBTQ community and for marginalized populations. Because basically examines the stressors from the point of view of oppression, or from the point of view of intersectionality of oppressive feelings. So it was developed by feminists because most of the therapeutic approaches until that point were developed by white males, and it didn't really address the needs of female clients. It is basically the two core tenets make these very effective, again, for any marginalized group. They create an equal relationship between the client and the therapist, and they assume that the client is an expert on his or her own life, not the therapist. So from a vertical position, until then, most therapists were actually, I am the expert and I'm going to tell you how to fix this, right? This approach basically says, I don't have an answer to how to fix your problems. You know better than anyone else who you are and how to fix this. And they very gently, through the same techniques that insight-oriented therapies use, transference, countertransference, and the free association, and pointing out of defense mechanisms, these therapies will slowly get the client to find who they are and what is going on and how to get out of the conundrum, right? How to untie the knot, so to speak. But it's very effective, again, for people that feels that otherwise they're not heard, right? And then they will approach a therapeutic relationship with discomfort or distrust because they'll have someone else telling them what to do from above. So the approach is very, very helpful in that sense. It's still used for female clients also, because if you think about females that are in abusive relationships, for example, or females that feel marginalized otherwise, and they go to a therapist and the therapist tells them what to do, they're likely not going to show up to the next appointment because they're not, they don't feel safe in that relationship. So this is a therapeutic approach that makes the client feel safer. And then we have narrative therapy, again, another modality. This was actually developed much later, in Australia, actually. Michael White and David Epstein are both from Australia. And they basically, the tenet from them is that everyone has their own story, and like a certain event in life might be narrated by different people in different ways, even though the reality is only one. And that you don't work so much with the real event, you work with the story that the person has, right? So think of an event in a family, for example, right? The birth of a new child. Mom might narrate the birth of that new child in a different way. Dad might narrate it in another different way. And the kids, the siblings, might all have their own way of narrating that event. So everyone might be talking about the same exact event, even like think about a Christmas party, right? Or any particular event in your family. If you put all the family together to say what happened that day, all of them had different stories. And they might have points in common, but one might have focused more on on what happened in the hospital. The other person might have focused more on how the baby looked, and the other person might have focused more on how the car ride was to the hospital. So everyone will have a different story of the same event. And that when the therapist talks to this client to process the story, they're not focused on the real event, they're focused on the story. Because the story is what it's guiding the behavior and the feelings of the client. Group therapy. And this is very important. I know a lot of you sometimes think, group. I want my loved one to have individual therapy. Group therapy, never works. And that's sometimes true, but ideally, again, a holistic approach with both individual and group therapy is the best approach. Now, sometimes certain group therapeutic modalities might not work for everyone, but they're different, again, therapeutic modalities that can be used in groups. Now, it's important to know that for group therapy, the therapist is not teaching or doing therapy with the clients. The therapist is a facilitator. Group therapy actually happens in the group. The group is the therapist. So that's why you cannot discard group therapy as something that should not be part of treatment. Because obviously that therapist, the group, it's not available when you're doing individual therapy. And there is wisdom sometimes in the group. And there is, the clients have the opportunity to learn from each other a lot more than sometimes from the therapy. Again, a top, like an expert approach sometimes is not the best approach for clients. Psychoeducational groups, again, the premise in here is that education is treatment. I actually do, when I do group therapy, I love to do psychoeducation. I think it's important for people to know what one as a therapist is doing and why are we doing it. It provides information, it provides socialization techniques, it models and provides hope, and it can be very preventative and growth oriented. I can tell you my favorite psychoeducational groups with the clients are, for example, teaching them about what is psychosis and how does it work, and how and what can I do about it, and because that is part of CBTP, right? If I know what psychosis is and if I know how these symptoms work, I will know also that I can question the value of these symptoms. I could question the power of these symptoms, which is what we were talking about when we were doing CBT. Another great group that is a psychoeducational group that I love to run is a group on anxiety and where anxiety comes from, right? From an evolutionary perspective. So making anxiety relate to evolution, right? Why do we have a fight or flight response and how it was useful? And how now we fight and fly from things that we don't need to fight and fly, and why is our reaction, that intense? And again, insight into that, knowing that that's where my reaction comes from, what will help clients understand why they feel the way they feel and why are those symptoms the way they are. And it's a good start to provide, again, to give hope, to give understanding, and to understand why is it that I'm working in this technique in my individual session. And then psychotherapeutic groups are actually the true group therapy, in where the group is the therapist. And what happens in here is basically the therapist make comments directed to the whole group and then reflects on the process that is operating in the group. So it's using the same sort of principles that we were talking before as transference and counter-transference, but in the group. So, if, for example, the team of this group is patients, right? And a client starts talking about like, oh, I'm patient because I do this, this, and that. And another client might say, well, you're not patient because the last time we talked, you were not nice to me, And the therapist will intervene and be like, okay, well, let's try to figure this out and, and make it an educational experience to both, because what we're really addressing is the transference and counter transference in between those two clients. And then you might bring it up to the whole group and say, okay, in what ways this makes you feel this way or this other way? Does anyone identify with the feeling of this client or this other client? And that's how, again, the group becomes the therapist, even though the therapist has a role of moderator and sort of facilitator and sort of guiding, to use these transfers, counter transfers in a more healthy way. But ultimately, the group is the one that does the therapy when you do psychotherapy group. And these are the bottom-up approaches, and these are all the other therapeutic techniques that go beyond, the both CBT modalities and the insight-oriented modalities. These address your limbic system, which is your primitive brain. It helps clients that have difficulty accessing their frontal lobe as the first stops. Like we were saying before, it helps clients that don't have the other pieces of the puzzle get this piece of the puzzle. How does this feel in my body? By getting input of sensory information, clients are able to find the other pieces of the puzzle and sometimes make sense of what's going on. Prefrontal cortex is not involved in these processes. We are simply talking to this primitive brain that understands sensations. And by changing the relationship with this primitive brain to sensations, we kind of create new neural pathways towards the frontal lobe, towards the prefrontal cortex. Bottom-up examples are therapy. Again, we use different media to create artistic pieces, and as we create this media, we are able to connect with feelings, thoughts, behavioral expressions. And music therapy, same thing. Pet therapy, again, the very sensational relationship with the animal creates this sort of bottom-up approach that starts with the sensation and creates a new neural pathway to the frontal lobe. So I think that is all I have. If you guys have any questions, as usual, I would say that I will be sending this out with any other additional material that I have. But if you have any questions now, I suppose we have another couple of minutes to answer those questions. Yes.
I have two questions, and I don't think I can even form them into questions, but early on, when you were saying something about thought, feelings, and something else, how do you get them to talk about their thoughts? Or, I mean, that's the first garbled question. I mean, do you try to get them to think about their thoughts or talk about their thoughts? I don't know.
So usually, at least one of the techniques that you use depending on the client is you teach them about their experience, right? And again, like we said, the experience has 4 pieces of the puzzle. So thoughts, feelings, behavior, sensations in your body. So we try to basically have them find the pieces of the puzzle, whichever piece of the puzzle is that they find. And from there, you find the other pieces. One group that we run here quite often is actually, it's called the Elements of My Experience, and it combines music with this sort of experiential thing. It's not music therapy. We do have music therapy, but it's not. It's just basically, let's practice identifying the elements of my experience. I'm going to play this music, and you're going to tell me, how it makes you feel in your body, what it makes you, what feeling are you experiencing, what thought are you experiencing, what does it feel like doing, right? And clients might or might not be able to find all the pieces of the puzzle, but by finding at least one of them, then we can expand on, like, okay, so this is how your body feels. What feeling is associated with a body feeling jittery and tense, right? Like, and then we go there. Or some people actually goes directly to the thought. Oh, this makes me think that guy is crazy because he's thinking about, whatever, like nothing is going to work out. Oh, okay. So what happens when we think that nothing is going to work out? Well, then you get anxious and nothing gets done. So then we go, we find the other pieces of the puzzle by practicing this. And then again, that's in group, right? When you go to individual therapy, you might do that with your own thoughts or your own feelings. But it depends on who the client is and, how do you find the pieces of the puzzle. And that you do with your therapist. But most CBT therapists will look at all the elements of the experience and try to figure out what's the way in.
And the other one is, I can't remember the context, and I might not be able to ask it quite, but one of the things you said was there was a phrase in a list that said something about before there's even psychosis, that there's something about, there's some way that there is therapy to determine if there's going to be psychosis. Do you know what I'm saying? It was one of the last things on a list. Is there a way to determine if there's going to be psychosis before there's ever That is the question, because I guess is there a way to determine there can be psychosis before there ever is?
So the answer is like maybe. I think therapeutic approaches are not designed to determine that. That's more, you're asking more of like, can it be assessed?
It was on a list is all I'm asking.
You can use these therapeutic techniques before the psychotic thought is formed to prevent to help the client prevent the value and power to whatever psychotic thought might come. And that for some programs like the STEP program, or like programs that do early psychosis intervention or psychosis prevention, might teach this to their clients, so that when more frank psychosis shows up, clients know what this is, and they're not, like, say, not believing all the delusional thinking, or at least questioning it more than if you believe your delusional thinking and if you're manic end up in California because you think that you're going to be a movie star. Like, maybe if you have the techniques before you think that way, you might actually not buy the airplane ticket. But that's just like one example, right? Like, sometimes if you know the technique before the symptom happens, you will question your belief, even if you cannot get rid of the belief, which is the thing that happens with psychosis. You cannot sometimes get rid of the belief, but you can at least say, well, do I have to believe this, or do I have to do what this thought is telling me? Do I have to do what these voices are telling me, right? Which is helpful for clients. So if that's taught before it happens and clients know how to use this, it helps. It helps prevent acting on those things. All right. Well, thank you again for being
here. No, thank you.
Thank you. Thank you so much.
Oh,
all your sessions are very informative. If you don't mind, I just had a quick question. I mean, how does one decide which therapy to explore with your loved one?
Well, so I would say that is a question to the therapist that is treating, right? And also, you want a therapist that knows what he or she is doing. So you don't want to ask a therapist to do some things that they don't know how to do. So I would say the first question to the therapist is like, what are you trained on, right? And what techniques do you use for this particular disorder? And then use those techniques, because you want your therapist to be an expert on what they do.
Right.
Yeah.
Yeah.
Okay. So
Thank you so much.
And as always, I will be sending all the material over, okay?
Thank you.
Bye, guys.
Thank you, Rista.
Bye.
Bye.